Imagine a cancer so intensely aggressive that it practically just melts away the moment you hit it with chemotherapy.
Yeah, the scans just completely clear up.
Right. The primary mass vanishes, and, for this brief window, it really looks like a total victory.
But it's usually not.
Exactly, because despite that dramatic initial response, fewer than 10% of patients actually survive 5 years.
It's a brutal statistic.
It really is. So today we are doing a deep dive into the paradox of small cell lung cancer, or SCLC.
Yes, looking at how modern medicine actually fights it.
Right. We're taking this massive stack of current clinical oncology protocols, specifically the 2021 ESMO Clinical Practice Guidelines, and we're decoding the war room strategy used to battle one of the most elusive diseases in human biology.
It really is a war room type of situation.
Definitely. So for you listening, whether you're navigating oncology rounds right now or, you're simply fascinated by the absolute frontier of medical science, this is an exploration of how doctors map and attack a microscopic enemy that adapts, frankly, faster than we can track it.
And to really understand that strategy, you have to appreciate the sheer biological hostility of this disease. I mean, SCLC requires an entirely different therapeutic framework compared to almost any other malignancy.
Yeah, it's really in a category of its own.
It is. It's actually categorized as an orphan disease in Europe. So we're talking about a prevalence of just 1 to 5 per 10,000 people.
Wow, that's rare.
Very rare. And it is overwhelmingly tied to a single environmental trigger, which is tobacco smoking.
Right, the smoking link is huge.
But what is truly concerning, just from a public health standpoint, is the shifting demographic. Decades ago, this was mainly a disease of middle age.
Right.
But from 1975 to 2010, the proportion of patients presenting over the age of 70 jumped from 23% to 44%.
Okay, let's unpack this core biological paradox because this is what makes SCLC so terrifying to me. You have this tumor that exhibits an incredibly rapid response to first-line platinum-based chemotherapy.
It melts away.
Right. So if it's so susceptible to the drugs, the subsequent drop-off in survival seems, I don't know, completely counterintuitive. It feels like we are winning the battle on day 1, but then completely losing the war by month 6.
Yeah, and the reason for that is the very mechanism that makes it vulnerable is actually what makes it so lethal.
How so?
Well, SCLC has an extraordinarily high mitotic index.
Meaning the cells are dividing super fast.
Exactly. They're dividing at a furious pace.
Mm.
And since traditional chemotherapy targets rapidly dividing cells by damaging their DNA, the initial tumor mass practically disintegrates.
Which sounds like a good thing.
It does. But that hyperactive replication cycle also means an astronomically high mutation rate.
Ah, I see.
So while the chemo is wiping out 99% of the tumor, there's this tiny fraction of microscopic clones that are rapidly mutating. They're undergoing genetic shifts and, well, developing robust resistance mechanisms.
So by the time the cancer repopulates, it's like a totally different enemy.
Precisely. It is a fundamentally different, completely chemo-resistant enemy.
And because that replication cycle is measured in days rather than months, our standard early warning systems are, well, they're completely useless.
Totally ineffective.
Like routine CT screening, which is the gold standard for catching non-small cell lung cancer early, it totally fails to improve survival rates for SCLC.
Right, because it presents almost exclusively as an interval cancer.
Yeah, which means it pops up between scans. It's like relying on a CT screen for this is like having a security camera that only takes a picture once a month.
That's a great way to put it.
The burglar is so fast, they've already robbed the house and left between the snapshots. The cancer doesn't just develop in that blind spot, it actually metastasizes and spreads systemically before your next scheduled scan.
Which, as you can imagine, fundamentally alters the preventative strategy.
Mm.
I mean, if secondary prevention like catching it early on a scan is mathematically impossible due to the tumor's doubling time, then primary prevention is the only viable lever we have.
Meaning stopping the cause in the first place?
Exactly.
Yeah.
That is why smoking cessation isn't just, a nice lifestyle recommendation here. It is the absolute cornerstone of managing the disease burden.
Right.
You have to eliminate that primary mutagenic trigger because once that biological cascade starts, our surveillance technology simply cannot outpace it.
So the reality is, by the time a patient actually presents with symptoms, the disease is already moving at breakneck speed.
It's everywhere.
Right. So the clinical focus immediately shifts to mapping the threat. And the diagnostic blueprint here demands histology over cytology.
Yes, that's a crucial distinction.
Because SCLC is a high-grade neuroendocrine carcinoma, so just looking at a few loose cells from, like, a fine needle aspirate isn't enough, right? Doctors actually need to see the architectural context of the tissue.
They do, yeah. They have to rule out other neuroendocrine tumors or malignancies that would demand entirely different therapeutic pathways. The tissue architecture provides this definitive genetic and structural fingerprint.
Okay, so once that high-grade neuroendocrine status is confirmed, what's next?
The immediate next step is staging. And while oncologists officially utilize the TNM 8th edition classification, tumor, node, metastasis, the actual treatment paradigm in the clinic relies on a much more pragmatic binary division.
Limited stage versus extensive stage disease.
Exactly.
And that division, it isn't just about measuring the volume of the tumor, is it? It's actually a structural limitation of our weapon.
Yes, it's entirely about logistics.
Like, limited disease essentially means that cancer is confined to one hemithorax and the regional lymph nodes, meaning the entire macroscopic tumor burden can realistically fit inside a single, safe radiation field.
Right. The moment it spreads beyond what a single targeted radiation beam can cover without, destroying vital organs, you cross the threshold into extensive disease.
And that spatial constraint basically dictates the entire curative intent.
It does. But before a single dose of radiation or chemotherapy is even administered, physicians have to navigate this highly complex systemic complication that's pretty unique to neuroendocrine tumors.
Right, because SCLC cells frequently express proteins that are normally sequestered way behind the blood-brain barrier, like exclusively in the nervous system.
Exactly. And when those proteins show up on the lung tumor, it triggers these paraneoplastic neurological syndromes.
Wait, so the patient's own immune system starts attacking their nervous system because it's confused by the cancer. What does this actually mean for the patient's experience?
What's fascinating here is the sheer variety of the collateral damage. So a patient might present with severe cerebellar ataxia or muscle weakness or Lambert-Eaton myasthenic syndrome.
Which all look like purely neurological issues.
Right. They look neurological, but they are actually autoimmune crossfires triggered by the lung cancer. The immune system is essentially destroying the spinal cord or the peripheral nerves in this misguided attempt to kill the SCLC.
That is wild, and recognizing that crossfire completely changes the calculus of treatment, doesn't it?
Oh, absolutely. We'll get into immunotherapy shortly, but if a patient's immune system is already hypersensitized and actively destroying their own neurological pathways, taking the brakes off that immune system with modern checkpoint inhibitors could be catastrophic.
Because it would just accelerate the nerve damage.
Exactly. The map of the disease isn't just spatial anymore, it's immunological.
Which forces a highly customized approach. But let's assume the immune landscape is stable, and we're looking at the best-case scenario limited stage disease, where a definitive cure is the actual goal.
Right. That's where the aggressive multi-front assault begins.
And surgery is practically off the table here, right?
Right.
Used in fewer than 5% of cases.
Barely ever used. It's strictly limited to tiny T1 or T2 tumors with absolutely zero mediastinal lymph node involvement, which has to be confirmed by rigorous pathological staging.
So for the vast majority of patients in this limited stage, the definitive weapon is concurrent chemoradiotherapy.
Right. Systemic cisplatin and etoposide overlapping with thoracic radiation.
And the debate over how to deploy that radiation was one of the most contentious issues in thoracic oncology for years.
Oh, it was a massive debate.
Because you had the CONVERT trial specifically tackling the fractionation schedule. You essentially had two competing philosophies. One was a 66 gray dose delivered once daily over a prolonged 6.5 weeks.
Right.
Versus this highly aggressive 45 gray dose delivered twice daily over just 3 weeks. It sounds like we're choosing a blitzkrieg, bombing enemy supply lines twice a day for a short period, rather than a slow, drawn-out siege.
That's an excellent analogy. And historically, the hesitation with that twice-daily blitzkrieg was pure toxicity.
Because of the damage to the chest.
Exactly. Delivering hyperfractionated radiation to the center of the chest carries a massive theoretical risk of severe radiation esophagitis.
Meaning the esophagus just gets destroyed.
Yeah, essentially destroying the mucosal lining of the esophagus to the point where swallowing becomes impossible and the patient requires a feeding tube. Because of that fear, many clinics just defaulted to the once-daily, slower approach.
But the CONVERT trial basically disproved the inevitability of that collateral damage, didn't it?
It did. The leap in modern imaging, specifically 3D conformal radiotherapy and intensity-modulated radiotherapy, means the beams are sculpted so tightly around the tumor that the surrounding healthy tissue is largely spared.
So the toxicity rates between the once-a-day and twice-a-day cohorts were virtually identical.
Yes, which completely validated the hyperfractionated twice-daily standard of care.
And the radiobiology behind why the twice-daily approach works is pretty elegant.
Very much so. Because SCLC has such a rapid repopulation rate, dragging the radiation out over 6 weeks gives the surviving tumor clones time to proliferate between doses.
Right, they just heal up.
Exactly. By compressing the entire treatment schedule into 3 weeks with twice-daily hits, you induce catastrophic DNA double-strand breaks faster than the cancer cells can initiate their repair pathways.
Yeah.
You outpace their biological resilience.
It's all about speed. But the assault doesn't stop at the primary thoracic site. Even when the patient achieves a complete radiographic response in the chest, there is this lingering threat of cerebral metastasis.
The brain is a major problem area.
Yeah. So the standard protocol for responders is prophylactic cranial irradiation, or PCI, basically delivering 25 gray to the brain simply as a preventative measure.
And the necessity of PCI really comes down to the pharmacokinetics of the chemotherapy.
Right, the blood-brain barrier.
Exactly. The blood-brain barrier is an incredibly effective filter. It prevents large neurotoxic molecules from entering the cerebral spinal fluid.
Which normally is great.
Normally, yes. But unfortunately, cisplatin and etoposide are largely blocked by this barrier. Microscopic SCLC clones, however, easily breach it.
So the brain becomes a pharmacological sanctuary site for the cancer.
Yes. PCI sweeps that sanctuary, neutralizing the microscopic seeding that the systemic chemo couldn't reach.
Wow. So in limited stage disease, we deploy this highly synchronized, aggressive combination of systemic cytotoxicity and localized hyperfractionated radiation to just corner the tumor.
That's the goal.
But what happens when the cancer has already breached the walls? Let's move into extensive stage disease. Because for nearly 3 decades, medical science hit a grim, unyielding wall here.
It was incredibly frustrating.
The median overall survival for extensive SCLC using that exact same platinum etoposide backbone sat rigidly at just 9 to 10 months.
For 30 years, decades of clinical trials attempted to break that ceiling. Researchers tried dose escalation, novel targeted therapies, maintenance chemotherapy. I mean, nothing moved the needle.
Nothing worked.
No, the tumor microenvironment of SCLC was just too hostile, too adaptable, and universally deemed immunologically cold.
Well, here's where it gets really interesting. Because the Empower 133 and Caspian Phase 3 trials finally shattered that 30-year standstill.
They really did.
They introduced immune checkpoint inhibitors, specifically anti-PD-L1 monoclonal antibodies like atezolizumab and durvalumab, concurrently with the standard chemotherapy.
And the median overall survival pushed to 12.3 and 12.9 months.
Right. And for you listening, an extra 2 or 3 months on a median scale might not sound like a miracle paradigm shift if you're healthy, but the real victory is found in the long-term tail of that survival curve, isn't it?
The tail of the curve is exactly where the triumph lies. At 18 months, the atezolizumab cohort demonstrated a 34% survival rate compared to just 21% in the placebo group.
That is a massive jump.
It is. And if we connect this to the bigger picture, the addition of PD-L1 blockade proved that SCLC is not entirely invisible to the immune system.
Which we previously thought it was.
Exactly. Previously, the tumor's rapid growth simply outpaced T-cell infiltration, and it actively cloaked itself by expressing PD-L1.
And that PD-L1 binds to T cells and essentially forces them into an exhausted, dormant state.
Right. So the immunotherapy drugs physically block that interaction. They strip the cloaking device away, reawakening the exhausted T cells and allowing the patient's own cytotoxic lymphocytes to recognize and slaughter the neuroendocrine cells.
It took 30 years to find the right pharmacological key to unlock that immune response in SCLC.
And it managed to achieve this survival benefit without significantly compounding the toxicity profile.
Which is huge.
It's a critical metric, especially when treating a patient population that is predominantly over the age of 70 and carrying heavy cardiovascular or pulmonary comorbidities from, decades of smoking.
Right. But surviving that initial extensive treatment regimen is a massive milestone. But the clinical reality of SCLC is that relapse is almost inevitable, usually occurring within 6 months.
Sadly, yes.
Which brings us to the complexities of survivorship and second-line strategies. The oncological approach to relapse is entirely dictated by what's called the treatment-free interval, right?
Correct. The biology of the relapse defines the very next move. If a patient experiences disease progression more than 3 months after completing their initial chemotherapy, the disease is classified as platinum sensitive.
Meaning the tumor might still respond to the original drugs.
Exactly. The tumor biology suggests it might still be susceptible to DNA cross-linking agents, meaning oncologists can re-challenge the patient with the original first-line regimen.
Okay, but what if it comes back faster?
If the relapse occurs in fewer than 3 months, it is platinum resistant. The clonal evolution of the tumor has rendered those original drugs completely obsolete.
So for those resistant rapid relapses, the traditional European standard has been topotecan, which I understand is notoriously difficult to tolerate.
Very harsh drug.
But there's a massive shift happening with lurbinectedin, right? It's a transcriptional inhibitor that recently secured orphan drug status and accelerated FDA approval.
Yes, lurbinectedin is very promising.
Because by binding to the minor groove of DNA and blocking the transcription of tumor-associated macrophages, it's demonstrated a response rate of over 35% in these relapsed settings. It offers a completely novel mechanism of action when the platinum drugs fail.
It does. But, beyond the relentless pursuit of pharmacological control, the holistic management of the survivor requires intense vigilance. The long-term physiological toll of both the disease and the radical treatments creates a highly fragile ecosystem.
Like with the brain radiation.
Right. We mentioned prophylactic cranial irradiation earlier.
Yeah.
The cognitive sequelae of whole brain radiation are a well-documented risk, particularly in the elderly.
And I think this is where the diagnostic rigor of modern oncology really shines, because it is incredibly easy to look at a 75-year-old patient who develops severe memory loss or confusion 6 months after getting PCI and just write it off as inevitable, irreversible brain damage from the radiation.
But the protocols strictly mandate looking beyond that obvious assumption.
Wait, so if a patient gets confused after getting brain radiation, doctors shouldn't just assume it's brain damage. It might literally just be a vitamin deficiency caused by the chemotherapy.
Absolutely. Because treating the whole patient means recognizing the systemic devastation of the therapies themselves. Chemotherapy regimens like cisplatin and etoposide completely obliterate the body's metabolic and nutritional reserves.
Oh, wow.
So a patient presenting with dementia-like symptoms might simply have a profound chemotherapy-induced vitamin B12 or folate deficiency, or they might be suffering from severe clinical depression, or even an undiagnosed progression of underlying vascular dementia.
And those are highly treatable, reversible conditions.
Exactly. Assuming every cognitive deficit is permanent radiation damage denies the patient access to simple restorative interventions.
It's really about maintaining dignity and preserving the highest possible function in the time they have won back.
Very much so.
And inextricably linked to that quality of life is the absolute necessity of smoking cessation, even after the diagnosis is confirmed and treatment has started. Because there's this persistent, fatalistic myth out there that once you have lung cancer, the damage is done, and quitting smoking doesn't matter anymore.
I hear that all the time, and the biochemistry says the exact opposite.
Tell me why.
Well, continued tobacco use actively sabotages the molecular efficacy of the treatments. Radiotherapy, for example, relies heavily on the oxygen enhancement ratio.
Okay, meaning?
Radiation generates free radicals in the presence of cellular oxygen to inflict permanent DNA damage on the tumor. Smoking causes chronic tissue hypoxia. It literally starves the microenvironment of oxygen.
Oh, so it acts like a shield.
Yes. It renders the tumor cells significantly more resistant to the radiation beams. Furthermore, for those who achieve remission, continued smoking exponentially increases the risk of developing a secondary, entirely distinct primary lung malignancy.
So you could survive SCLC just to get a different lung cancer.
Unfortunately, yes.
Wow. We have really mapped an incredibly complex battlefield today. From dissecting the biological paradox of a tumor that divides so fast it basically guarantees its own resistant survival, to the precise spatial logic of limited versus extensive staging.
A lot to take in.
It is. We explored the radiobiology behind the twice-daily blitzkrieg approach in the chest, the pharmacological necessity of sweeping the brain with PCI, and finally, the historic immunotherapy breakthrough that shattered a 30-year survival wall by uncloaking the cancer to the patient's own T cells. For you listening, you now hold a comprehensive map to the absolute frontier of oncological science for large cell lung cancer.
It really is a testament to the relentless, iterative nature of medical research. But we always have to remember that tumors biology is equally relentless.
Which brings us to a final, mind-bending reality hidden deep in the molecular pathology of this disease, something called transformed SCLC.
This is truly wild biology.
There is a subset of patients who develop a completely different, traditionally slower-moving lung cancer, non-small cell lung cancer, driven by an EGFR genetic mutation.
Right.
And doctors successfully treat these patients with highly targeted, elegant tyrosine kinase inhibitor pills. But in 3 to 5% of these cases, the targeted drugs place such extreme evolutionary pressure on the tumor that it utilizes phenotypic switching.
It changes completely.
Literally. To survive the drug, the cancer alters its own histology. It rewrites its biological identity, transforming from non-small cell lung cancer into the highly aggressive small cell lung cancer we just spent the whole show discussing today.
And this raises an important question about the true nature of what we are fighting. We meticulously map our strategies, we develop our targeted inhibitors, and deploy our radiation fields with pinpoint accuracy. But we're engaging an enemy capable of rewriting its own genetic and cellular phenotype simply to evade our best weapons.
It's terrifying.
It is. It leaves you wondering just how boundless the evolutionary adaptability of these microscopic enemies really is.
It's a stark reminder that we aren't just solving a static mechanical failure in the body, we are engaging a living, evolving organism. And that is exactly why the science and the search for the next breakthrough, frankly, never stops.